Well, good evening, everyone who's joining us, and for those who are logging on. Thank you for joining ORNAO for their educational webinar. We'd like to thank STERIS for sponsoring tonight's session. I have the privilege of introducing Lena of Fogle to present to us on creating an ecosystem of safety in the operating room. A little bit about our speaker this evening. Very seasoned healthcare leader with over 30 years of experience in various roles, with over 15 years as a perioperative leader, including those of educator, manager, director of nursing, and consultant. Lena has developed and taught various programs on topics that include surgical or perioperative practice, process design using lean principles, patient safety, leadership, workflow analysis, and all aspects of the perioperative patient journey, as well as mapping that journey, clinical excellence, and evidence-based practice, as we would come to expect. A description of tonight's session is really around the surgical care environment and what it must contain for the best outcomes for patients. And so the surgical care environment contains many elements that must be optimized in order to deliver safe patient care and to create a safe place of employment. Failure to account for certain elements in the design of the perioperative environment may result in surgical site infections, decreased efficiency, negative effects on staff, compromised cybersecurity, or negative patient outcomes, all integral in our patient planning. An integrated environment of care must be established to create a safe clinical environment. To ensure the highest quality environment for both patients and staff, the design of a surgical suite must address such elements, including air quality, equipment, and room layout. Really looking forward to tonight's discussion and education, and I'd like to hand it over to Lena. But before I do that, I'd like to remind all attendees to please remember to mute. You should automatically be muted now that we're recording. And then also, if you look at the very bottom of your screen on the toolbar, you'll see a chat icon. It's the third one from the left. And so we would ask you to type any questions or comments in the chat, and we will moderate those at various times, perhaps throughout the webinar this evening, and certainly at the end. And so I would like to pass it over now to Lena. Thank you in advance, and I look forward to learning. Thank you.
Well, thank you. And thank you so much for having me. I'm delighted to be able to present this to nurses in Canada and operating room personnel. And the genesis for this presentation was really thinking through how historically most operating rooms have attacked their issues by focusing on the human factors, communication, leadership, checklists, protocols, policies, processes. And those are extremely important, no doubt. But there's also something to be said for the design of your operating room, which can do much to mitigate a lot of the risks that the patients and staff encounter working in this critical environment. And that's what we're going to focus on today. Having an optimal environment can help you focus in on the human factors that can drive your performance in an even more progressive way. So with that, I'll go ahead and get started. I've already been very nicely introduced. Thank you so much. I really appreciate the introduction. And so I did originally make this presentation focused in on the US, but understanding that we're in Canada and talking to you guys directly, I did do some research in some of your organizations that govern your practice and regulate your practice. And what we're going to be talking about today, I'm hoping by the end of this, you'll at least have some familiarity with the idea of what are the elements that can help you create a culture of safety in the operating room. And some of the consequences of an ineffective safety culture, along with what are some of the best practices around designing a surgical suite, and what are the key factors one needs to consider when creating that environment, and what are the different elements that go into things like patient safety, staff safety, ergonomics, and an efficient and pleasant workplace for the surgical team. We all know all across the world that surgical nurses enjoy a less lengthy career because of a lot of accumulative muscular disorders, cumulative back injuries, cumulative physical injuries, as well as mental stress. So we can't leave out our staff safety when we're thinking about designing an operating room, one of the key objectives. So we've had a very rapid advancement of surgical technologies, including, as we all know, MIS surgery, robotics, advanced imaging equipment. We are seeing MRORs going up all over the place, of course, hybrid suites, et cetera. And it's causing a lot of hospitals to think through a redesign of their surgical suites to accommodate this new equipment. And just so you guys know, a new operating room can cost anywhere from $1 to $3 million US dollars per surgical suite. So it's really important that institutions involve a rigorous interdisciplinary planning committee before making that investment. And unfortunately, what we see over here stateside very often is the end users, the nurses, surgeons, techs, and other ancillary personnel that are working in those rooms day in and day out don't have a seat at the table to really discuss their needs. So that's something that every hospital should make sure they include a very large clinical voice when they're redesigning, renovating, and revamping surgical suites. I don't know about you guys, but I've been in surgical departments where I walk in and, the boom is facing the door and you can barely get out through the back door behind anesthesia. And the bed is placed so that the patient's legs are facing the door and all kinds of things. And you wonder to yourself, look, how did we get here? How is this room so difficult to maneuver in and work in? And so the goal in creating and maintaining that environment of care is to ensure that hospitals and surgery centers allow every patient to receive quality care without undue risk, and to make sure that surgical staff are working in a safe, efficient, pleasant environment, which makes a big difference to how the day goes and how we get through our working lives in the OR. So when constructing or renovating a surgical suite, a lot of attention needs to be paid to evidence-based design. So there's a lot of evidence around the impact that the design has on outcomes for patients and work-life balance for the other stakeholders that work in the operating room. And we want to reduce patient anxiety and stress by having them come into a safe, pleasant environment when they're getting ready to have surgery. There are research studies out there that suggest that the less anxious patients are immediately prior to surgery in the suite really impacts their recovery. And I don't mean just how they feel about their recovery, but I mean the amount of pain medication that they require, the recovery time they require, even wound healing has been associated with that. And so what is some of the equipment and best practices and systems that we need to be thinking about? The number one thing that I don't think gets enough attention when we're talking about providing an aseptic environment is the air in the operating room. I don't go into detail here, but I do have another CE that really talks about air quality and all the things that go into that. But suffice to say that there are many studies that tell you about 98% of wound contamination comes from the air or is transferred from surfaces into the wound where bacteria containing particles that have been floating in the air are landing on back tables, instruments in the wound directly. That is the primary culprit in surgical site infections. And I hate to tell you guys this, but you guys are the primary carriers. So you're sloughing this off your skin constantly in the operating room. And if the particles are small, they'll stay suspended in the air and hopefully get flushed out through a great air delivery system. And anything that is not flushed out will then sort of dribble down onto surfaces, including back tables and instruments, surgical wounds, etc. So air is probably the number one thing that needs to be considered for aseptic technique. How operating rooms are cleaned, the lighting systems in operating rooms, of course, the surgical table, kind of the bread and butter of patient positioning, any kind of warming systems that you have in place, For staff safety, effectively evacuating surgical plume or smoke is very important. How devices talk to each other is very important for your workflow, and any kind of adjunctive technologies that help you to support safe patient care and outcomes. So in addition, of course, to meeting patient needs and safety, today's hospitals are patient-centered, but they're also should be human-centered institutions where patient safety is intertwined with the health of everyone in the room. An optimized physical environment is an important tool in making hospitals safer, more healing, and better places to work. There was a very large literature review conducted, and it concluded that reducing staff stress by having ergonomic interventions, as well as careful considerations to other things such as air quality, noise, and light, can have a significant impact on staff health. In addition, attention to the needs of personnel communicates to the staff members that maintaining their health and safety is an important goal for the organization. So maintaining that safe environment of care in the surgical suite also requires attention to staffing numbers, of course, staffing training and availability, but having the right workflow in a room, the right zones, the right clear spaces to move, the ability to get where you need to get to, interconnecting devices really all go a long way to having an ergonomic space that's more efficient. So meeting the needs of other stakeholders. So there's also other stakeholders beyond the staff in the room and beyond the patient themselves, right? So really need to involve internal and external stakeholders in the design process for any renovation, construction, or revamping of that space. The more viewpoints you can have at the table, the more perspectives, the better your design will be in the final stages. So you want individuals with a diverse area of expertise to provide that input on functional design, what the users of that space need, how we can best prevent infection, how we can support sustainability, of course, our regulatory requirements and environment, many other things. It's also important to make sure that patients and families feel well cared for. We know that overall, when patients trust the healthcare workers, and a lot of that has to do with the environment, what you're seeing around you, the noises you're hearing around you. And when families feel that their loved ones are in good hands, we know that that enhances their perioperative experience, but also their postoperative experience. We want to make sure that we can allocate resources where they're most needed. In this way, we really can reduce potential overhead and expenses throughout the entire continuum of care. So what are some of the real world consequences of that ineffective safety culture? And what I mean when I say ineffective safety culture, I mean operating rooms that are very congested, very crowded. Equipment has multiple screens that people have to learn and walk around the room to use. Lots of cords for tripping hazards, lots of nooks and crannies, a lot of stuff in there, which makes it very hard to clean and keep clean, those kinds of things. So I don't know if any of those sound familiar to you, but I've worked in a lot of ORs like that, and I've been at my time in Steris in a lot of ORs like that. Very small, and over the years, we've added more and more equipment and more technology, which is important and good for patient care as long as it is not so disruptive to the workflow that it's not being used effectively. So just taking a look at Canadian surgical patient safety, I learned that over 1 million surgical procedures were performed. This was an annual report between 2004 and 2013. So I'm sure that's grown, but that's the most recent. They do it about every 10 years. So you're about due for one. And of course, the stated mission of the Canadian healthcare system is to provide safe care, but even with that mission and even with the great work of all of the nurses and surgeons and staff in the operating room, incidents still occur, as I'm sure you're aware. And over half of the incidences that are reported, adverse events that are reported to the Canadian healthcare system, over half of them are attributed to surgical care. This is a very high risk area. Lots of great things happen there, but the risk is very high for untoward events as well. And so what did they identify on the things that got sent over, and what they got reported on is that 53% of all of the incidents reported to CMPA were surgical related. 49% of everything reported to Hierarch was a surgical incident. Some of the categories were 2/3 of the cases involved non-oncology, non-trauma. So these are going to be elective surgeries and urgent surgery. Trauma-related care represented about 12% for one agency and about 3% for the other. Patient harm included things like injury to organs, blood vessels, nerves, wrong surgery, wrong site surgery, unintended retained foreign bodies, hemorrhages, burns, and of course, SSIs. Still continue to have retained foreign bodies every year, amazingly enough. And some severe patient outcomes, including death and catastrophic harm, were identified in 32% and 39% of the surgical incidences. So the most common system issues included inadequate lack of and/or adherence with surgical safety protocols. So that is kind of a human factor, but it's very hard to adhere to very firm surgical safety protocols when your rooms are really not set up for it. It's very hard. It's a lot of noise. It's congested. It's crowded. It's busy. So it's very hard to depend on human processes. And most of the incidences occurred during the intraoperative phase. So in the operating room, not pre-op, not in recovery room. And of the specialties that had the highest incidences, it included neurosurgeons and orthopedic surgeons. So harmful events in Canada, this was a study that was done for the years 2022 and 23. It estimated that 1 in 17 hospital stays in Canada involved a harmful event. You guys are right in line with the US and everybody else. So it is a very high risk environment. 47% of the harmful events were related to healthcare and medications, things like bed sores, medication errors, and surgical errors. Infections were way up there. 31% of the harmful events were related to infections like surgical site infections. Included in that bucket were also hospital-acquired infections, so CLABSI infections, deep line infections, etc. But most of them, the lion's share that were reported were surgical site infections. 18% were procedure related, like bleeding after surgery or something that happened during the intraoperative phase. And then there were also patient accidents. A lot of people think that falls is really high up there, but if you take a look at the data, that's only about 4% of the harmful events. So a lot of most of this is within control. This is not not known or expected complications of surgery. These are actual medical errors and preventable harm, right? And so focusing in on SSIs for a second, what are some of the human and economic tolls of surgical site infections? So the estimated cost of an infection, additional care cost, is about $28,000 per case. And complex SSIs, those are deep site, like total joints and implant SSIs. Their 12-month total cost was about $95,000. And SSIs that involve a prosthetic implant can cost more than $90,000. Of course, it results in prolonged hospital stays. It can increase the length of a hospital stay by 9.7 days. Length of stay is directly related to the cost, the economic toll, as well as the human toll, as well as the staff toll, and your capacity to be able to take care of all the patients that have needs when you have these additional hospital days. There's increased cost per admission. Patients with SSIs are much more likely to be readmitted even after their original infection was treated. Patients with SSI need more outpatient visits. They occupy a lot more emergency room visits and home health aid care. Patients with SSIs may end up needing more durable medical equipment at home. And of course, all of the economic cost is borne by the taxpayers of Canada in these instances. So we've taken a look at what are some of those consequences. I'm just highlighting again some of the main things. Intraoperative hypothermia is a big problem for patients. It really hinders wound healing and patient outcomes, surgical site infections, of course. And in Canada, surgical site infections experts have estimated it to be between 35.7 and $45 billion annually in additional care for patients and in costs for that kind of patient care. Improper patient positioning, we all know that we can cause injuries through patient positioning. Pressure injuries are a big problem, and they're interesting because, they have a delayed manifestation. So most surgery nurses will not know patients coming out of the OR have the heralding lesion that will lead to a pressure injury down the road in 2 or 3 days. Of course, retained surgical items as well. So I'm going to pause there and just make sure that nobody has any questions about what I've gone over so far. And I think, James, you agreed to man the chat. Has
Of course.
anyone?
I have not seen anything yet, but anybody feel free to drop your questions into the chat, and I would be more than happy to facilitate them over to Lena. But at this point, we have just an introduction from Linda. So hi.
Okay, and then just to point out, I'd love for this to be interactive. I'd love to hear from you guys who are the experts in bedside patient care. If you've experienced any of these things and what your thoughts are about some of the adverse events that we've talked about. So please feel free to speak up. We're happy to, at the end, if you want to tell us a story, anything you want to put in the chat or comments, I really welcome it. Okay, so sorry, I went past that. So let's talk about some staff injury and stress. So burnout, anyone? I think surgery nurses are at high risk for burnout over a certain amount of time. Sort of some low-level chronic illnesses like back pain, neck pain, actual injuries. I think the operating room is a place where the trip hazards are pretty immense most of the time. And headaches from inadequate lighting, task lighting, all those kinds of things can really over time take its toll on our precious healthcare workers. So they remain a very important goal of good ergonomic design. We all know that ORs are congested and complex. We also know that we have a lot of advanced diagnostic and imaging technology, as well as lots of other equipment. Due to this, they've become even more congested and complex. And in a modern OR often contains, booms, surgical tables, lights, room lighting positioned throughout the room, lots of surgical displays. But if you haven't ever heard of the term of operating room integration, which a lot of nurses, that's more of an industry term. But what we mean by that is having a system that'll enable you to connect all of your disparate devices that have screens and controls and be able to control a lot of those from a central station, touch screen, so that you can route different images up to different displays. You can control certain devices, the music in the room, conferencing from there, taking images and videos of the surgery from there. So these days, I think we still have a lot of operating rooms that are not integrated, but it's only a matter of time where it's going to become so overwhelming to manage all the different pieces of equipment in the room, much less violating a lot of the zones of the operating room as you're trying to walk around there, which increases the risk of SSI. I think personally that it's only a matter of time when every OR will need to have some level of integration. There's simple integration all the way to very complex integration. It really depends on the types of procedures and the type of room that it is. And then I guess you've all probably been hearing a lot about cybersecurity issues. Hospitals are grappling with a lot of cybersecurity issues, not only protecting electronic information and infrastructure from the unauthorized access, use, and disclosure, but protecting patient privacy as well. And also ransomware runs rampant in hospitals, where hospital systems will get stolen basically and hijacked and held hostage for actual monetary gains. So as annoying as cybersecurity issues can be for frontline people who are trying to sign on and get onto their stuff, it's extremely important that there's a good backbone of cybersecurity for all the data that's housed in a hospital.
Lena, just a couple of quick, if you have a second, we have a couple of
Yeah,
comments that might be good to follow up with.
yeah.
I'll go just on the topic that you were just speaking on, cybersecurity. So, Helen F asks how best to deal with cybersecurity, and then I'll move up to Aileen's question as well.
So how best to deal with it? If I could just, was it Helen that asked that?
Yes, yeah.
If I could just ask Helen, could she be a little bit more specific at how to deal with it from a hospital standpoint or from an individual user standpoint, Helen? You can unmute and talk if you like.
Okay, maybe we'll come back to that one just for time's
Okay.
sake. And we will, the one of the other questions when you're talking about staff safety was, do you have any data on the impact of noise pollution in the OR?
Oh my gosh, that's a great question. Um, I I don't have at my fingertips a study, but I can tell you that noise pollution is a big problem in the operating room, not just for your hearing and the wellness of your hearing, but also for being able to communicate effectively. So I don't have it, but I'm sure that there's many out there. I've read them in the past. And so noise should be a primary concern. And I think it's up to industry to make sure that they're making things that are much quieter and hit below that 60 decibel that we all talk about. Anything beyond that is a problem. So, a really good question. And just going back to the cybersecurity question from Helen, I
So I
really
think it
think
was
it's
a different question, to be honest with you. She's got a few points in here and it says, look for complete questions. So I'm going to piece this together. So staff and management are sometimes reluctant to address issues with larger size scrub nurses. Gown may not fully wrap around their backs in size. Jewelry can be an issue. How best to deal with this question? That was
um,
her question.
okay. So
I'm sorry, we're not supposed to mention her name.
no, that's okay. But I
Okay.
think what she's saying is how can the nurse in the operating room address those when personnel have exposed jewelry, when their gowns don't wrap around, right? That's what she's asking.
Mhm.
Yeah. So I've got one word for you, straightforwardly is how that needs to be addressed. I really think that it needs to be if you're circulating that case and you're the ORRN, you really need to manage all those elements in your case. And I would just say, your jewelry needs to come off. Let me find you a different gown. I know that it can be uncomfortable, but if you set yourself up as a patient safety advocate and speak up, I think you'll find over time you can get more comfortable with that. And then people know that that's where you are and what you stand for. And they'll stop trying to come in the room with a bunch of jewelry dangling all over the place. Of course, you can always pull a policy to go over that part of your policy that talks about jewelry and fitting of the gown, covering everything. You can talk to your manager, but if it were me, and it was my case that I was circulating, I would be very direct because it's important and it's no time to work. People need to understand that you're a patient advocate and that's what your goal is and that's why you're there. So I always encourage my employees to address it head on. And if they still had trouble, then go to their manager.
Perfect. And just one last one, we'll let you get on the move here.
Yeah.
Just a few comments from different people, but all around the same thing. So, we were talking about staff injuries. So there had been some staff injuries relating to tripping, with one staff member sustaining a fractured wrist, cords during the end of the laparoscopic case. Also, shoulder injuries from the amount of lights and monitors placed over the head of nurses. And the last one is, even with fantastic integration, there seems to be limits on the IT support available. So nurses now have to have a minor in IT troubleshooting along with their patient care role. So all kind of related to that staff challenges slide that you had, Lena.
Yeah, absolutely. So the cords, we hear this consistently, is the number one thing that surgical nurses wish we could get rid of in an operating room. I think what's important when you have cords running across the floor, et cetera, is that your facilities department, your leadership need to get those button down onto the floor, out of the way, approved extension cords. Of course, having rooms that have good booms that move around the room really help with that, because then you can tuck in all of your data and your power right into the boom. That helps remove a lot of cords off the floor. Where cords are 100% necessary, there are devices that can cover those cords, get them flusher to the ground, etc. That's really important. And when it comes to IT support, I could not agree more. I think hospitals struggle with that. I think it's difficult for nurses to navigate the changing environment with technology and integration and IT concerns. So I think what's important there is that sometimes when you have issues and you can't get a hold of someone and you're just doing your best and then you're letting it slide, you're getting to the next case. I really think it's important to escalate those issues so that your collective voice can drive more IT support in your department, whatever that looks like. There are IT liaisons that are assigned to the perioperative environment who are supposed to be there to help you with those things. Unfortunately, I think that it's just probably not going to get easier because we're gonna keep moving forward with new advances. But I think pushing for IT support in your operating room is really important. You can probably make the case if you escalate the issues that you're experiencing, and you should really push to get approved extension cords, approved ways to button down your cord so that tripping on them becomes less. And then as far as your lights go, coming down low, you really need to consider the height of the table against the height of the lights. And this is a little trick for surgical lights. Most people take both surgical lights, if you can see me, and they butt them up right next to each other and they point them straight down on the wound. Not only does that increase the risk for shadows and things, but a clinical tip for you, and just try this, is to take one light over all the way to the end of one side of the bed, the other light all the way to the other end, and then bend them both so they're co-illuminating, but they're not right over the wound, which will really help get them out of the way for the people that are right there over the wound, and it'll actually drive more light into the cavity. Just try that and see if that helps. Okay, moving on. Okay. So I'll just skim over this, but I think everybody knows that we've touched on it, that we need to have reps working through this design that have a wide array of perspectives. I bet we never saw environmental services represented when they're designing an operating room, but they should be. Your infection control folks can really help drive the types of technology you need in that room to prevent infection and make your room more hygienic. And what I mean by hygienic is easier to clean and the ability to stay clean better, right? And of course, perioperative nurses should play a huge role in this. There's a lot of evidence around making sure that your room is designed with evidence in mind. And it really is based on the level of protection required. So evidence-based design is really the process for creating healthcare buildings informed by the best available evidence concerning how the physical environment can interfere with or support activities of patients and staff. Patient-centered environments really should be focused around reducing infections, decreasing stress on personnel, and improve patient healing. Many improvements suggested for evidence-based design are only slightly more expensive than traditional solutions, and sometimes not more expensive at all when you take in the total cost of ownership. So some examples include things like integrating facility design, which is adapted from sort of Toyota production so that you have zones and you have things logically moving through the entire continuum of care. So you want a human-centered design that's thinking about solutions to complex problems for user groups. It enables personnel to express ideas, gain knowledge, and make decisions. So we'll talk a little bit more in depth about what that means in the operating room itself. But in the middle of all the decisions around the operating room design should be the human-centered care. The humans in this scenario are your patients and you that have to work in that OR every day. So we all know about the zones of the perioperative department, right? The unrestricted, the semi-restricted, and the restricted. But have you ever applied these principles to the operating room itself? It can be very beneficial. So zones in the operating room could be thought of like this. So each of the 4 zones, there's 4 zones we like to talk about in the operating room: the sterile field, the circulation pathway, the movable equipment zone, and the anesthesia zone. All of them should be of sufficient size to accommodate the number of anticipated personnel and the amount of fixed and mobile equipment. So AORN, our association in the US, really has spelled these out and defined them. So this is really important because I think even if you take your existing operating room, even when you don't have a renovation or a new build coming, if you reimagined your operating room, thinking of these zones could be really helpful to you. So they're defined by AORN. The sterile field zone includes the OR bed, a clear area on each side for personnel, and outstretched patient armrest, and a clearance at the foot of the bed for personnel and equipment. So we all know what the sterile field is. Expand that out and consider that a zone. That zone, sterile people need to stay in there and non-sterile people need to stay out of there. The anesthesia zone includes that sufficient space for the anesthesia professional and all of the equipment that they need. And the circulation pathway zone includes the back table and other sterile equipment and personnel in surgical attire. It should accommodate the movement of 2 people in sterile attire and allow them to meet and pass each other without touching each other. So this is beyond the surgical field and onto your circulation pathway of your sterile personnel, right? And then the movable equipment zone includes any equipment not needed in close proximity to the sterile zone, like garbage cans, case carts, etc. So when you think about looking at your room and maybe moving some things around and considering those zones. And sometimes people have been aided in a pilot program where they want to zone out their operating rooms and they'll use floor tape to create those zones, and they'll see how people are able to stay out of the zones that don't involve them and stay in the zones that they need to stay in, and see if that improves ergonomics in the operating room and efficiency in your workflow. So just a little hint you could take back to talk about what can we do to establish those zones in the operating room. It should not be a free-for-all in there. And then creating an environment of care requires that selection and maintenance of systems and surfaces and equipment that support that safe environment. And some of those things, we touched on this, the airflow in the operating room could not be more important to preventing surgical site infections. It is the #1 thing. So you want to decrease the airborne microorganisms by filtering the supplied air, so filtration, diluting the contaminated air through your exchanges. That's what you're doing there when you are creating when you are creating your air exchanges in the operating room. You are diluting the contaminated air, thus reducing the amount of contamination. And then the positive pressurization of your operating rooms, which is preventing contaminated air from entering into areas outside of the OR. And I know door openings can be very challenging. You should never prop a door open in the operating room when during a case or even right before or after, because then you are negating your positive pressurization. You shouldn't be coming in and out during a case unless you're coming in through a subroom, if at all possible. And there was a study that was done where on average, and this really surprised me, but on average, there's like 27 door openings per case across this one study. When they studied why the doors were getting opened, most of the time it was for no reason. It was people opening the door. Hi, how are you guys doing? When are you going to be done? Hey, what's going on? Hey, have you been relieved for lunch? Hey, blah, 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 blah. Those kinds of things that really are better dealt with without opening the door. So airflow in the OR is very important. You've all heard of laminar airflow, but really a better way to say it is that you want a unidirectional, high velocity airflow that's pushing clean filtered air down and pushing contaminants away from the patient. So there's a lot of ways to, a lot of different kinds out there, but we do know that a single large diffuser is the best way to have a clean column of air that's coming down without air gaps. So when you're looking at those are really important. The prefab, there's prefab, everything is going to modular these days. It's very helpful. It decreases the downtime in the OR. You don't have to do a stick build. There's lots of air purifiers that, in addition to the high velocity air that's coming down, there's actually purifiers that are pushing down and helping to sanitize. And a lot of them harness the power of the sun and use UV light to sanitize the air. And HVAC maintenance is super important. So your filtration is always what it needs to be. The single most important thing you can do to reduce SSI, believe it or not, is to get your airflow right in your operating room. So we talked about data and video integration systems. We know that having that real-time access to that critical information, being able to have enhanced consultations and aligned collaborative surgical teams is really important to outcomes. Standardization and accurate collection of patient data is really important. I don't know how often at your facilities you're taking pictures, but what I see typically is images being taken for most MIS cases. And those need to be pushed to the medical record. They need to be shown to families. They need to be saved so that doctors can use them for education and teaching. So having a good image management system is also really important. And when you're talking about the design of the suite, and if you need to make sure that the minimum recommended number of electrical outlets are available. Of course, there's suction ports, oxygen ports, medical air, instrument air, waste anesthesia lines, and a lot of respective zones of the surgical suite, like the operating room, the recovery room, procedure rooms, and sterile processes areas. You need to consider all of that. Also consider your OR surfaces, like the materials you used in the construction of the OR walls, cabinets, and countertops. They need to be hygienic, which means non-porous and easy to clean. So when you think of tile with grout and mortar in there, even when you think about drywall, very porous, it can harbor microorganisms. There was a study done that had spores growing in drywall. So not your best material for an operating room suite. Type of wall material really does play a role in the overall cleanability of the walls in the operating room. Of course, we know that we have stainless steel panels, high pressure laminate. Drywall's not a great choice. It's very porous. Glass panels are a great choice. Glass is extremely durable. It's infinitely recyclable. It's very hygienic and easy to clean. So lots of things to consider there. And also it's virtually maintenance free. So encourage your facilities to think of their overall cost of ownership. So drywall might be cheaper up front, but I know that in one of my customers pulled the data and they spent about $1,000 a month in maintaining their drywalls with all the bumps and holes and scrapes and repainting and all that stuff. I'll pause there because I see James manning the chat. Do we have more comments or questions?
Unmute myself. Yes, we do. So just a couple here.
Okay.
First one is Sylvia says, for cords, I previously worked at a hospital that had orange mats that went over them. So just a bit of a tip on potential solution. Then we have a question saying she was surprised to hear that SSIs were higher in ortho and neuro. Any thoughts as to why?
Yeah, so of course, one of the main things is that they're so catastrophic that they're one of the reporting requirements. So in Canada, those are there's surveillance on total joint. But the other reason that they're so high there is anytime you're putting a foreign item into a patient, so think of spine, think of knees, hips, whenever you're putting implanting a foreign item in there, and you're also down in bone, right? And so bone can become infected in a very insidious way. You can have sort of a low-grade infection that parks there for a long time, and it's very hard to get rid of. You're also in a deep cavity. If you're down in a joint and you're down in a spine, also another factor would be the length of the case. So the longer the case is going on, the higher your risk of developing an infection for the reasons I talked about, the air quality in the room and things landing onto the air particles landing onto the wound and landing onto your back tables. You're also doing a lot of tissue trauma when you're doing neuro and total joints. You're doing a lot of damage to the surrounding tissue. You're doing a lot of pulling on tissue, tugging, hammering, nailing, inserting, and all of that trauma to tissue makes its ability to fend off infection less. So for all of those reasons, I think that joint infections and bone infections and neuro infections are very high, whether you're going into a skull, into a spine, into a joint. But really good question.
That's a great point, Lena. That was very well done. So last comment is just open doors. You were talking about that in the environment. So I love the idea of collecting data to put a real number to this so staff can gain a cleaner sense of the impact on door opening on air in this restricted zone preventable. Just a comment.
Yes, I think you could do a clipboard study if you have committees on perioperative practice. You have nurses that are on those. If you have any process improvement teams, etc., you could have a clipboard study, which means park yourself, outside a room and literally count door openings without telling anyone what you're doing.
Yep.
And then you can present the data afterwards to enlighten people, because they're going to be very surprised, because most of these door openings are happening without a lot of conscious thought about the impact, right? And so they're not aware that they're opening them as often as they are. But I really think collecting that just for a few days would be well worth it. And then also another way to do that, if you can't do that, I always say that part of changing a culture is storytelling. So one recommendation I always have on the human side is every staff meeting, though you and your fellow nurses might not have experienced a deep SSI, maybe you haven't experienced a retained item, maybe you haven't experienced a death on the table from bleeding, etc. But many of those instances occur, and there are many case studies. So you hate to think that everyone has to learn everything the hard way. So I always say at the beginning of a staff meeting, prepare a little case study of a real life case that has occurred, 5 minutes. Explain who the patient was, what happened to them, and what the consequences were. Tons of them out there, open source, that you can get. And telling that story is a way to make it sticky for your staff and get them to start thinking about those things. So just a little idea there.
That's
Anything
great,
else,
Lena.
James?
No, that was it. And I've actually been personally involved in a clipboard study as a rep and watching kind of how that came about. And unfortunately, somebody walked in with a bagged lunch that sits behind the patient. So they brought some really big things to light in that one. So you're right. That's a very effective way, as long as you're silent about what you're doing. That's how they So a lot of hand clappings and comments just about being interesting to see what they'll find in their ORs and things like that. So active point, Lena. Thank you so much. So
Awesome.
you
Awesome.
can keep on rolling. Thank you.
Okay, and we are getting we're close to being efficient. I want to see finish, so I want to see what time it is. I still have about 10 minutes?
Yeah, you've got exactly. Yeah.
Okay.
We
So
are
I'm
rolling.
just gonna briefly touch on lighting. Okay, so everybody thinks about surgical lights, and those are very important, but I want you to also think about ambient lighting in your room, task lighting in your room, because having bad overall lighting in the room is really going to contribute to eye fatigue, unwanted shadows in the room, trips and falls, etc. So I do a great CE on lighting and when you're doing MIS and the room is dark, what's the complementary light, and how can you still see what you're doing in the room? And then of course your surgical light needs to promote laminar airflow. If you have a big dome sitting over your surgical field, even if you have laminar flow, it's being obstructed by those domes. So having something that is that works with laminar flow is important. And video monitors. So used to be that surgeons operated on what they could see, magnified by loops, etc. But today, surgeons are guided by these video monitors. In many cases, that's a trend that's going to continue. Laparoscopic new procedures are expected to grow year over year. And so you want monitors that promote a comfortable posture for the surgeon assistants and scrub nurse. If everybody's twisting their head to look at the one monitor in the room, you can bet that you're going to end up with neck pain, etc. Booms, greatest thing since sliced bread. If they're done right and they're in the right place and they have the right outlets and the right shelves. So boom design, I don't think anybody should be designing a boom unless they're consulting with the end users on what needs to be on that boom, how long the arms need to be, where the patient's going to be, all that kind of stuff. Booms can be your best friend, though, for all your problems around cords, around getting equipment to the patient, moving it out of the way, etc. The optimal OR bed, just as a general thing, you know, working height is generally at the level of the waist or the elbow. Surgical tables these days need to be able to do a lot. They're very complicated. They need to be able to go very low, go very high, tilt, trend, be able to accommodate many accessories. So you want a general surgical table that gives you the maximum flexibility and the maximum ergonomics to step up. You want a nice slim base. You want to be able to get up to the table. You want cutouts so your knees fit underneath for the sit down, you know, GYN procedures, etc. So pick your surgical table based on future proofing it. So maybe you don't need all of what it can do today, but you probably will sometime in the future. So you want to get something with maximum flexibility. Okay. Pressure injury prevention. About 2.5 million patients develop pressure injuries. That's United States data. I'm sure Canada's would be less, but proportionally probably the same. I'm here to tell you that many pressure injuries, the heralding lesion, the sentinel lesion occurs in the operating room and you can't see it. When you turn a patient over to move them onto their recovery room bed and you see a little redness and you think, oh, well, they've been laying here, and you kind of rub that red spot and you move them on over, that could very well be the heralding red lesion that may culminate in a stage 3 or 4 pressure injury once they get to the floor. So pay special attention to those. Hypothermia. Okay, so hypothermia, unplanned hypothermia may contribute to a lot of patient complications, thermal discomfort, obviously, but adverse myocardial outcomes have been demonstrated with hypothermic patients, alterations to the pharmacodynamics of anesthesia and other medications, as well as delayed wound healing, blood sugar issues in the post-op area, increased pain, etc. So what I always say about hypothermia in the operating room, and this is proven, it's much easier to keep a warm patient warm than warm up a cold patient. So that amount of time from the time they come into the room to the time you have them positioned, prepped, draped, and ready to go, this is the time that you need to deploy active warming measures so that they don't get cold right in time to get a big incision. And then it's very hard to warm them up because they're actively losing heat through their incision, anesthesia drugs, etc. So focus on pre-op warming in the operating room, pre-incision warming from the time they walk in to the time you're ready to cut. And use active measures. The warm blankets out of the cabinet are great for a minute, but we all know that in a minute they're back to room temperature and they're not actively warming. So think about how you can deploy that and what you can do about that. And then the physical layout impact and potential for, I got an applause for that. That makes me so happy. Thank you. Impact on potential for flow disruptions. So the layout really has an impact on that. I'm sure you've been in many ORs. You're like, who thought of this? Who thought of having, you know, not even being able to open the door for all the equipment that is in there? I do think part of your, I'm just going to say this because we're running out of time, and this will be fully recorded and the whole presentation will be available. But I think what I would like to say is that your terminal process in a room at the end of the day really should include removing equipment that you don't need anymore to just relieve some of the congestion in the room. You really need to think through what you can get out of there, what is stacked in there just because it's in there, or just if you absolutely need it, right? So just like you're purging your closet, if you don't need it, get it out of there. It's much better to pull something in as needed than to pile everything up that you don't need in there. Staff protection. So providing equipment for patient handling and movement. All right, now this is one where it's having something to help you transfer patients and move patients that doesn't involve a lot of lifting, tugging, pulling, pushing is really important. There's lots of low-cost devices out there that can be very effective, like slide sheets, etc. Having the patient at the right height to move them and having enough staff to move a patient safely. It's going to be really important for your long-term health. And evacuating, I cannot say enough about this. Evacuating surgical smoke at the source and making sure it's getting filtered down to the tiniest particle. You wouldn't believe what's in all that stuff. And there's 150 toxic compounds in there, including viable living fragments of cells, bacteria, viruses. There's a case study. If I had time, I'd go over it with you, where we have a surgeon that got HPV in his nose from surgical smoke, and there have been many other cases. Surgical nurses in the United States have a 49% higher chance of developing COPD than the general population. And this has been controlled for, these are not people who smoke, these are not people exposed in any other way. It's strictly from being in surgery. So remember that, evacuate that smoke. So I think I'm going to make it in time, but just to say, we have a couple minutes left, but in summary, I know this is a lot of information that we've gone through, but if you don't have a renovation planned, get into your rooms, see what you can do to create zones in your operating room, see what you can do to cover up those cords, whatever it takes. See what you can do to get unneeded things out of there and the clutter out of there. If you do have a renovation or a new build coming up, make sure that you and your coworkers have a seat at the table and you start thinking through what's going to work in your operating room. And air. Make sure your air is protected by keeping those doors closed, making sure you have good air filtration, good positive pressure, etc. So these are some of the things that action items you can take back. So combat that complacency that builds by examining your workflow and looking for opportunities to improve. Involve your frontline staff in prioritizing what their safety and ergonomic priorities are. They know best what they need. Do an audit, do an ergonomic and safety audit in your operating room. There's lots of tools that exist out there. Okay. And I'm going to stop sharing. We have a couple minutes left. Does anyone have any other? I'm finished with my presentation. I kind of rushed through that last little bit, but I think you get the picture, and I'm really happy to have been in front of you and be able to talk through these things. James and I and the entire STERIS team is available to you. If you should have additional comments, questions, if you want some tips and tricks and some ideas, I'm chock full of them. Email me and I'll be happy to talk through anything with anybody. It's my passion. So any final thoughts or questions that anyone has to share?
We'll see if anybody unmutes. There's quite a few thank yous. It's been very informative, great presentation. Glad to know that every little act in the OR goes a long way. And I think this presentation was a great reminder that we can all do better as well, and we can point things out. It's a team environment. So Lena, that was very fantastic. So we really thank you for being able to be available to take care of this for this evening. It was fantastic. And I
Yeah,
see
and
that Denise
guys,
has put her hand up as well too, so that's
yeah.
fantastic.
Thank you. That was really excellent in terms of a great overview of some practices that, some of us have routinely, but definitely always looking for areas for improvement. You've left me with some great ideas. Tomorrow is my Wednesday morning session with staff as an educator, and so I love the idea of the case study. I think that will be quite powerful. I also, when you were talking about lighting, I was thinking about other ORs that I've been in. I want to say the St. Catharines site is newer than the OR that I'm in, but they had lighting. I think McMaster does as well, but lighting that was like red or green or whatever would be complementary, which it would be so great if that was standard in operating rooms for that.
Yeah, so
lighting.
exactly. And just to mention that, we didn't have time to go into it, but I do have a lighting CE if you're ever interested in that. But one of the things is during MIS surgery, surgeons are looking at red primarily. And the opposite in our eyes from red is green. So when they look up from red into a room that is flooded with green, it doesn't fatigue their red rods, right? So that's why green is a great ambient color for MIS. There's a lot of science behind that. And then task lighting is really important for your circulators, your anesthesia providers to make sure they have good task lighting. Warm task lighting is preferable over cooler, like bluer lighting. The more yellow lighting is better because it's in the green family, so warmer color temperatures. And yeah, there's a lot you could go over about lighting. So
And there's one
yeah.
other comment in terms of, what was I going to say now? The zones in the OR. I love that you compared unrestricted to restricted, but talked about the OR suite specifically. And many of us may be familiar with a sort of a darker colored floor where the patient's bed would be, and really think about what that means if that's not
Mhm.
there already. I thought that was just excellent. So thank you. I'm going to open it up to any other questions or comments. It looks like we have lots of thank yous. And there's also a comment here, James, if you don't mind me just jumping ahead. Most of our
Yes,
IV
please.
poles have square wheels, not super unsafe, but frustrating. That's true. Square wheels, I love it.
That's hilarious. Yeah, get you some new poles, ladies and gentlemen. Like make it happen because trying to move those things around when they're all, and usually that's just going to be suture string up in there. That's what's causing that. So a terminal clean out is also helpful, but yeah.
Well, this has just been excellent this evening. Thank you once again,
Thank you.
not only to Steris, but to Lena as a member of the team. I look forward to perhaps, partnering at another time about another topic. But in the meantime, attendees will receive an attendance of certificate for CPNC or education development. And then we will have this hosted on the ORNAO website as well. So there will be a link that you can go back and look at it and recommend it to any peers that couldn't make it this evening. Really great. Thank you so much. Very happy
You're
with
so welcome. Thank you for having me. Thank you, James and Eva, for all of your work ahead of time. It was a real pleasure. So anytime, guys.
Wonderful.
Thank you,
Thanks, everybody. Have a
everyone.
fantastic evening.
Have a good one. Bye.
Thank you. Good night, all. Stay safe. Bye bye.